really technical talk today, actually, rather than a kind of general overview. We've obviously, the centre I lead, we've been working full time on the COVID epidemic really since, I think we started about January 9th of last year. I'm not intending to review all that work. It's well in the public domain. But in the last few months, we've been very focused on two particular topics. One is looking at the impact of vaccination, both globally in terms of vaccine rollout and in much more detail, obviously, for the UK itself. And I'll focus mostly on the latter. And then on, given the UK has been so affected by it, on new variants of COVID-19 with changed phenotype, particularly increased transmissibility and potentially increased severity. I'll also talk a little bit about work which I've been peripherally involved in, but really is the work of my colleague here, Nuno Faria, and his team on P1 towards the end of this talk. So I'll review the emergence of B117, the very strong evidence now of increased transmissibility, which has been verified by a large number of groups. There's somewhat weaker evidence around severity increase, but that is strengthening. A little bit about biological mechanisms, and then lead into how that has affected the UK situation and UK government strategy, informed by the modelling we and others have done as to how we exit lockdown, basically the finessing of relaxing social distancing measures at the same time as ramping up vaccination. So I'm going to shamelessly take the very nice animation from done by Emma Hodcroft and Richard Neera on the NextStrain website, just to show a little bit about the evolution of different clades of SARS-CoV-2 over time. And obviously, even right back at the start, the D514G mutation probably had rather increased transmissibility compared with the original Wuhan strain. You'll see the orange start to emerge here, and this is what has really dominated our lives in the UK. I mean that as a population as a whole in the last 3 or 4 months, because it has profoundly affected both the epidemiology and the public health impact of the virus in the UK. At the current time, I should say, over half the deaths the UK has experienced due to COVID-19 in the entire pandemic, in fact, close to 60% are due to this new variant. So it really took off in November, December. It's obviously spread widely across the continent of Europe, and I know it's been picked up in many areas of the United States already. This is not my area, I won't go into the details, but the interesting thing is the divergence plot, genetic divergence plot on the right-hand side, which highlights really how different the B117 lineage is from pre-existing lineages. Pre-existing lineages we were seeing from the original first wave of the pandemic in March of last year were evolving basically according to a molecular clock. This is highly divergent from that, and people like Andrew Rambo and others have suggested it's most likely to have arisen in some sort of immunocompromised individual with chronic infection where large numbers of mutations accumulated within a single host. Has a number of phenotypically significant mutations, but in terms of transmissibility, N501Y, perhaps 6970, though that's interesting from a surveillance perspective, and P681H are the most important. I'll come on to 6970, but of course that is the mutation or the deletion which is responsible for the fact we can detect this strain relatively easily using PCR testing. So I'll talk about analysis which makes use of genomic data, and we are fortunate in the UK that we've been doing more sequencing of SARS-CoV-2 than any other country, and this is now out of date. I think it's up to about 70k sequences since October 2020, but we've sequenced of that order, we sequence about 5,000 sequences a week currently. And we have 14, I think now closer to 20,000 B117 sequences. The second data source, which is even more numerous, is from just community PCR testing. The UK has a freely available uniform testing system for SARS-CoV-2 now. Basically enter your details on the website or phone a number, and either you get sent a test or get issued an appointment. And about a third of those tests are processed in very large capacity, high throughput labs using the Thermo Fisher TaqPath assay. And that unusually for SARS-CoV PCR tests has spike as a target, and the 6970 deletion causes that target to fail. So what that basically means, with really from about mid-November onwards, we have a very good proxy for the presence of this B117 lineage in about a third of PCR tested samples. And given we have been testing, well, certainly back in January, we were testing about 400,000 samples a day. That gives a very large number of tests. And finally, when I refer to severity, I'll talk about clinical data and particularly mortality data. Starting with the genomic data, this just gives an indication through to about the beginning of February of how quickly this lineage took off in the UK, starting really in the southeast, and then quickly followed by London and the east of England, rising to almost fixation, but not quite. We can maybe talk about that in questions. It's got to about 95% frequency in all areas of the UK. The population geneticists among you will know that if you transform the frequency plot into a log odds of frequency, then the slope of that, it does, if I were to show you, it's a pure straight line, and it gives you a sense of the transmission advantage this lineage has compared with pre-existing lineages. And with a correction for the generation time, you get an estimate of about 50% increase in the reproduction number just from this simple analysis applied at countrywide level. You can do a little bit better than that using correcting for sampling biases, work Eric Volz did as part of a paper, and I should say our paper will be appearing in Nature next week or so on this. Because we do so much sequencing, there are some biases to that. So if you subsample the sequences proportional to basically case incidence, you get a more unbiased sample, and then you can redo that kind of log odds frequency model at a regional level to look at the growth advantage of the variant. And then the other crucial thing, to have something which only relies on genomic data, you can then look at the effective population size of non-variant strains. And here, to do that, we pick the previously most dominant strain, B117, and then again get a very similar estimate of about a 54% transmission advantage. And you get that estimate changes over time, and I'll come back to this point later, that whilst it started closer to a twofold increased transmissibility, it declined a little later. And so that's why the bottom plot here shows a degree of sensitivity analysis to what else might have changed about the virus, most notably the generation time, namely or closely related, should I say, to the serial interval distribution. I mean, it's possible that part of the reason this variant spread more quickly is it maybe had a shorter generation time. So if we allow for that in the model, just as sensitivity analysis, we see it does indeed. If you assume the new variant has a shorter generation time, then you reduce the estimated transmissibility increase, but it's still of the order of 1.5, the green curve at the bottom there. So the second source of data is this S-gene target failure data from PCR testing, where people test positive on two targets, N and ORF1ab, but negative on the S gene. And that is about 99% specific for the variant from about mid-November onwards. Because we have literally, well, now millions of samples, because of the scale of PCR testing, it allows us to look at the spread of this variant in a lot more detail spatially and temporally. So here I'm just showing a subset of a few regions, so-called NHS STP areas, just a convenient administrative unit. There are about 42 of them across the UK. And I'm plotting overall PCR confirmed cases in each area in the thick bar at the top. And then for the subset, about a third, where we have the S gene readout, what the trend is for the variant, the S minus cases, and then the pre-existing non-variant cases. And then on top of that, the pink represents periods of intense social distancing, so-called lockdown measures. So we had a second lockdown in the UK from beginning of November to the beginning of December. Those schools stayed open, importantly, in that time. And then we had a third lockdown following that enormous peak, starting the beginning of January, and schools have been shut in that time. So you'll see in these trends, and quite clearly, is that whilst that second lockdown was able to push down the prevalence of, or the incidence, should I say, of non-variant cases, the B117 variant cases increased in all areas during even the second lockdown, and then accelerated when that lockdown was lifted, and only started to decline, well, just before the third lockdown. I should say just before that. That coincides with the Christmas period where there was effectively a lockdown in place anyhow. And you see that replicated across the country. You can be more quantitative, of course. So in a very crude empirical analysis, you can take each of those 42 areas in a set of 10 weeks and look on at the growth in cases of both non-variant S gene positive cases and variant S gene negative cases. Just do the ratio of the cases in each area from 1 week to the next. And that gives a sort of multiplicative week to week growth factor. And that's what I'm plotting on this plot here across all those regions and weeks. And again, you see a lot of noise, of course, in this sort of data, but you see a very clear signal that if you look at the ratio of those growth factors, but comparing S minus to S plus, across all of those weeks and all of those areas, the variant was growing faster than the non-variant. Again, a slight hint of a decline in that multiplicative advantage in later weeks, but only a slight decline, still staying of the order of about 1.5-fold multiplicative advantage. So again, I mean, just very basic statistics here. I mean, could this be due to the fact that maybe the variant did have a shorter generation time, something we can't completely exclude? Well, the effect of that would mean that in areas where in contexts where the non-variant was growing, had a reproduction number greater than 1, the variant would grow even faster. But also in areas where the variant was declining, if there was no change in the basic reproduction, in the fundamental reproduction number, fundamental transmissibility, the variant would also decline faster. But that's not what we actually see. If you stratify those same weeks and areas and just look at the number of area week pairs where we saw the variant increase but the non-variant decrease, we have 183 of those versus 3 where the reverse was true. And so we have a very clear statistical signal that this is fundamentally a more transmissible variant. We can then take that S gene target failure case data and actually directly estimate the reproduction number by area, and shows those areas on the map, and by week. And this is a joint analysis. I mean, using the Epidemia R package developed by Axel Gandhi and Swapnil Mishra and Sam Batt some time ago, and extended for this application. The advantage of doing it jointly, of fitting a reproduction number for non-variant and then an additive advantage, both of them as random walks, is you control other variability and you get more reliable posterior estimates. And if you do that, you can then estimate for each week and for each area the reproduction number of the variant versus the non-variant. And you see a very clear and striking pattern in the graph on the right-hand side, where no transmission advantage, you'd expect all the points to lie along that diagonal line, and they all lie at a line which is roughly, doesn't completely intersect the origin, but has a different slope, and the slope difference gives you an indication of the transmission advantage. the ratio we get from this analysis, I mean, whilst it is highly uncertain, is of the order of an 80% transmission advantage. But again, in the plot on the left-hand side, some hint, albeit there's a lot of statistical noise here, some hint of a decline in January. Initially, when we looked at this data, which was really in early December, we saw a hint also of a potential age effect. This plot here shows you the proportion of cases in 4 different age bands, stratified by whether they're S gene positive or S gene negative, namely non-variant or variant. And you see a hint from those data, particularly if you look at the 11 to 18-year-old age band in that window around, peaking around the beginning of December, of a higher proportion of variant cases in 11 to 18-year-olds than you see in the non-variant cases. But that kind of then disappeared thereafter. So we explored what might explain that. It's most likely to be a dynamical effect, perhaps, and it did coincide with the period of time when schools were open. So perhaps one thing which occurred was that we know that schools have not been a major venue for transmission previously for COVID, probably because the within school reproduction number has been below 1. It is possible from anecdotal data, particularly from London just before schools closed before Christmas, that this variant is sufficiently transmissible to push the reproduction number in schools to above 1. Not targeting children in any way, just as part of that blanket increase in transmissibility. But when we analyze this in detail, what we can do is, I mean, this shows those now just stratified by two different age bands. I'm just plotting the proportion of cases here in 11 to 18-year-olds overall for the variant and non-variant, non-variant in red, variant in blue. And you basically see the same pattern. I'm stratifying by region, by columns here. You can ask the question, can we explain that? If we fit a model to this which allows for the transmission advantage to vary with age versus not varying with age, can we explain the data any better? And the simple answer is no. We don't have any evidence that transmission advantage is any greater in children for this variant. Neither do we have any evidence it's any less, however. We've also done additional sensitivity analysis as to can we really see a signal of a change in the generation time? And the simple answer is no. The best, if you allow models to fit a change in generation time, one gets a very small decrease of about 5 to 10%. What these plots show is, particularly focused on the ones in the bottom, is what happens to that temporal advantage over time if you assume differences in the generation time between the variant and non-variant. The important thing is that really you don't change the fundamental estimates of how much more transmissible this variant is. They go down slightly, but they stay basically above 50%. There's another potential reason why we might see a slight decline in transmission advantage over a time period when there's intense national level social distancing in place, namely a stay-at-home order or lockdown. And that is because during that sort of period of time, social contact networks shrink. So the number of people any average person contacts drops dramatically, and people drop down to their core contact network, typically within their household, perhaps in a few cases, workplace contacts. And the effect of that might be that if you're seeing a smaller number of people, but for a larger amount of time. And the transmission advantage, if you call the transmission advantage of a particular strain X, it biologically likely increases infectiousness in some way, instantaneous infectiousness, the hazard of one person infecting another. But the reproduction number, which is what we basically estimate from epidemiological data, is non-linearly related to infectiousness. So you can parameterize it as saying that R is equal to the number of contacts per unit time, or not per unit time, over the course of infectiousness, multiplied by the probability that any one contact causes transmission to occur, causes infection. And the latter, that probability of infection per contact, will depend on infectiousness and the duration of the contact in the kind of standard cumulative hazard sort of way, 1 minus e to the b minus bt. If you assume a variant just increases b, therefore, but move to a regime where you reduce the number of contacts, but increase the probability of transmission per contact by basically focusing the contact network down on household contacts, then you can see, even though you have a kind of fixed increase in infectiousness B, that what you see manifest is an increase in the reproduction number changes and reduces over time. And this may explain the fact that when we look at contact tracing data, and this is in a Public Health England publication collected in the UK, and particularly look at secondary attack rates in households for the variant versus non-variant, we see an increase in the secondary attack rate in households of about 35 to 40%, slightly less than we see when we estimate the overall increase in the reproduction number to be. And it's probably down to this saturation effect. As for overall biological mechanisms, as well as just knowing whether people are PCR positive or negative, for these very large scale so-called lighthouse laboratories, the ones which give results for the S gene we've been using, we actually have CT values for every test undertaken, and they're highly standardized as well. So we can track over time for the variant or S gene target failure negative, the red cases, on the red lines on these plots, and then the variant, the blue lines on these plots. We can look at mean CT values over time across the entire country, and we see quite a significant difference. There are two different columns here. One is conditioning on CT values being less than 30, which removes a certain degree of noise from what are called single gene positive cases, which may be, they're just low, very high CT values where you're unsure whether they're variant or not. And we see it varies by gene, but we see roughly a difference of 2 in the CT value for the N gene and about 1 to 1.5 for the ORF1ab gene. And we can do more than that. We can look at the entire distribution of CT values. And we're now analysing these data using the very nice paper by James Hay and colleagues, some of them in the department I'm now speaking to, looking at how you can analyse these each week we have hundreds of thousands of samples, these CT value distributions, to get insight into the underlying force of infection and also other factors around viral kinetics. Just turning to the severity of B117, a number of groups have looked at this, and most notably the London School of Hygiene and Tropical Medicine group and also Public Health England. And so we really did a kind of complementary analysis to verify those results and focused on non-parametric analyses of stratified data. So we have more than this now, but the results I'll present, we were able to link 2,500 deaths to community PCR tests where we knew whether it was variant or non-variant. We knew the S gene results. And so what we've done is effectively a form of case control study. We stratify the data, those deaths, by the week they were tested, geographic area, ethnicity category, sex, I should say, should be in there, and a number of age bands. And then apply a number of methods to look at whether there's an excess risk of death. And it's quite important to do that, because if you just look at the data, which has been plotted here, the pillar 2, which is our community testing cases stratified by variant versus non-variant over time, and compare it with the deaths, you don't, even in the areas where the variant took off, knowing London, southeast and east of England, you don't see an immediate picture of an enormous, increased risk of death. And if you look at the ratio of deaths in each of those weeks to cases on the left-hand side of those plots, there's a hint at the end that the ratio is above 1, but in many of the weeks it's not significant. However, if you apply a case control weighting, compare like with like, you see a much more consistent signal. And that's what we did. We looked at a number of methods, a weighted case control analysis, and then conditional logistic regression are probably the two statistically most robust and actually closely related to each other. But you can also do a standardized case fatality ratio approach. And so if you look at this and calculate then what is the excess risk of death if you have the variant compared with non-variant, you're getting estimates between about 40 and 50% on average of excess risk of death. And this has been confirmed in a number of different studies, and I think now in a number of different countries as well. And it's fairly robust across different strata, whether you look at it, how you split the data. There are a number of caveats. The biggest caveat in severity analysis in the UK context is we can only link about 10% of deaths to an S gene result. Over half the people who get hospitalized never have a community test before they're hospitalized, and unfortunately the PCR testing done in hospitals does not use an S gene target. But there is other, as I said, I mean, Public Health Scotland have published a nice analysis which has also indicated a similar sort of increased risk of hospitalization for people who infected with B117. So that left us in really quite a difficult position, because I mean, the epidemic, I'm showing now the different data streams which are published daily by the UK government. The UK now puts an enormous amount of data online. And you see this is from May onwards for the case data, but you'll see the whole epidemic nearly the whole epidemic for deaths. You'll see that our second wave exceeded the first wave in terms of overall mortality and in terms of peak mortality and peak hospitalizations, and took off explosively, admittedly not quite as explosively as March last year, but not far off. And you see quite clearly in here the fact that, I mean, it's really been driven by the growth from mid-November onwards of the variant, as I said, accounting for now over half of the mortality in the UK. So our current strategy, given we went into our lockdown in January, which was nearly as stringent as the one employed a year ago back last March, which is, basically shut down the country, our strategy for getting out of this is to vaccinate people as fast as possible and lift measures in a rather cautious way. And this is where I mean, we've been fortunate in managing to roll out vaccine, both license for emergency use, a number of vaccines really quite quickly, and roll them out really quite quickly. There are clearly many uncertainties, you'll all be aware, in terms of exactly what the characteristics of the vaccine are, but we're getting more vaccine effectiveness data all the time. UK has also adopted a kind of controversial strategy of increasing the gap between first and second doses to give more people a first dose quickly. But I mean, this is probably proving to be the right approach. We have good data now, vaccine effectiveness data, which suggests that one dose of either the AstraZeneca or the Pfizer vaccine gives something like an 80%, after 3 weeks, something like an 80% reduction in the risk of hospitalization, and perhaps about a 50% reduction in the risk of infection. So we have been working closely with the government to try and inform their decision making as to how quickly basically they can relax social distancing measures. We have a number of models which are really quite mathematical models of transmission, really quite similar, which capture the complexity of the clinical care pathway for COVID, but also social distancing measures. These are kind of age-structured SEIR models fit to multiple data sources. We've done quite a lot of work, and I'm going to, in the interest of time, skip over this quite quickly, and I'll refer you to the Alexandros Hogan's preprint on quite general analyses of global optimization strategies of vaccine rollout, focusing on a range of both high and low income countries. But I'll actually focus on the work we've done in the UK, and where we use quite a sophisticated model fit to multiple data streams And we're fortunate in the UK having real-time, government collected data, which varies, not just case data, but we have real-time data on hospital admissions, bed occupancy, deaths, serology, and infection prevalence, large-scale infection prevalence surveys undertaken each week. So generally, we do quite mundane things with the model, like estimate what the R is for a particular week, which is important, generate weekly medium-term projections of case numbers. But perhaps more importantly, we can use the model to evaluate different policy options going forward. And this is what we've done in the last few weeks. This just gives some example of fitting this model to a variety of different data streams, serology in the top, hospital deaths, care home deaths, by different regions of the country. So what we've been doing is fitting up to, we basically fit up to data into mid-February and then ran the model forward under a range of scenarios for vaccine rollout, taking account of the vaccination already being done, using estimates of vaccine effectiveness, and then different scenarios for social distancing. So this shows kind of projected vaccine rollout. And on the left-hand side here, the plots are really showing we expect to be getting up to about 65, basically 2/3 of the population, including children. And remember, we're not vaccinating children. And so the ineligible bit at the top are children, but about 2/3 of the adult population, of the entire population vaccinated, about 80% of adults vaccinated. Vaccine take-up has been very high. So in over 70s, it's been above 90% take-up. We expect that to drop somewhat in younger age groups. But the vaccine, particularly with one dose, has not perfect efficacy against infection, which has been what's been shown here. And so only a certain proportion of those vaccinated will be fully protected against infection. And so we have a model of how population immunity and protection evolves over time. And then we layer onto it a set of government scenarios for lifting social distancing, parameterized as basically, if you take the reproduction number we would expect to see if there was no immunity in the population for this virus, what are the, starting with a starting point of a bit over 1, in real terms it's under 1, but that's because 1/3 of the population is now immune in the UK. And then we relax measures at different times. So here we have this really quite complex trade-off between how quickly population immunity is growing in the population and how quickly the virus is growing. We then translate that kind of reproduction number profile, those set of policies, into what the model translates it into what we would see in terms of the real reproduction number, the effective reproduction number, growth rate in cases over time under those different scenarios on the right-hand side. And then we can translate it into what that means for projected hospital bed occupancy under the range of scenarios, and then additional deaths, the deaths being plotted as cumulative deaths from the time point we ran the simulation in February. And so you see, I mean, still, despite the very fast vaccine rollout, if we just lifted social distancing measures completely, the most liberal curve, purple there, we would expect to still see at the current time really quite a catastrophic third wave of transmission. And so the government is really aiming for this kind of sweet spot, really between the green and the red curves there, is where the strategy is being tuned. The projections are uncertain though. I mean, you can tell from the confidence and credible intervals around them, there is an enormous amount of uncertainty. And that uncertainty grows as time goes on. So we've accounted to some extent for potential seasonality in these of transmission in these projections, but we don't know anything about the duration of protection of vaccine or naturally induced immunity, really. And we probably will, almost certainly the UK will have second generation vaccines by the summer. So, I mean, this is modelling which has gone straight into government policy, and indeed you can download it from the government website in terms of both ourselves, and I would also name check Matt Keeling's group in Warwick, who've done very similar comparable modelling, coming to very similar conclusions. So I'll just conclude with a little discussion of P1. We were fortunate to have Nuno Faria join us from Oxford, very talented geneticist and epidemiologist, with deep collaborative links with Brazil and Latin America more generally, runs the CADE Center there. And so we've been heavily involved in analysing what has been going on in Brazil with the P1 variant. And as you know, I mean, there's a lot of concern about it, really generated from the fact that Manaus in Amazonas saw a major second wave of transmission, despite having a catastrophic first wave of transmission. I won't go into the genetic details. I mean, it shares, I think this is an example of convergent evolution. It shares some of the changes of B117, but it has many other changes. So what we've been doing, and this really is Nuno and Sambat and a whole bunch of colleagues' work, has been a joint analysis of both genetic data and epidemiological data collected in Manaus in particular. Both sequence data, and what you see in the center here is again a frequency plot of the P1 lineage over time, showing a similarly, very rapid growth in frequency of the lineage as we saw for B117 in the UK. They also have, interestingly, some CT data, and just focusing on the plot B on the top, which would suggest, it's not statistically significant, they don't have the numbers, but suggest again something like a difference of 2 or 3 in CT values for the N gene, comparable to what we're seeing for B117. The interesting thing, though, is combining that data with the epidemiological data. So here you see daily numbers of deaths in Manaus in plot C in the middle top, and then the genetic data I've already shown, the proportion of P1 in the population, and then you can fit a model to that. And the model says that the variant can have a number of different characteristics, phenotypic characteristics. It can have a basic transmissibility increase. It can also escape immunity, so have a certain degree of cross immunity. So cross immunity of 1 means it's not escaping immunity at all. Cross immunity of 0 means it prior immunity from other infection with other strains has no effect on the variant. And then they also fitted in a potential increase in severity. And of course, as you would expect, given we estimated, and this is plot E here on the top right, that the population of Manaus may at least 60%, and it could have been as high as 75% of the population was infected in the first wave of transmission. That we see in the estimates of whether this virus has increased transmissibility versus cross immunity, a lot of correlation in the estimates. So plot A shows the posterior distribution from these fits for the estimated increase in transmissibility versus the kind of cross immunity. So if there's no cross immunity up at 1, then we're estimating the transmissibility increase for this variant is close to 3-fold. But the central estimate is that it has a similar sort of level of transmissibility increase of B117, namely somewhere about a 1.5 to 2-fold increase in transmissibility, but also is a partial immune escape variant. Cross immunity is at the kind of 0.5 to 0.6 level compared with 100% cross immunity. So we'd be predicting that there's a higher rate of reinfection, which partly explain these data. And that's basically all I had to say. I mean, I refer people to the preprints and hope, as I say, the analysis of B117 transmissibility will be coming out in Nature shortly, and other work on severity and on P1 hopefully will be published in peer-reviewed literature soon, but preprints are available. But I would just emphasize, I mean, the UK experience in the last few months has been somewhat catastrophic, building on not a great start with the first wave. B117 has accounted for half of UK deaths and a really, really rapidly increasing second wave in November and December last year. Most of that we attribute to the increased transmissibility of this variant. That's what basically meant that pre-existing control measures were insufficient to contain spread. But some of the increase is probably down to the estimated increase in severity as well. Vaccination is clearly the exit strategy we are all looking for, but I think our work on what we expect vaccination to actually achieve in terms of population immunity and how long that will take means that it will be a gradual process in terms of our ability to lift non-pharmaceutical interventions. In the UK, at least, given that we are now in an environment where basically 95% of the viruses we have are B117. We don't fortunately have any evidence of an immune escape for B117, but the partial escape variants such as P1 pose clearly even more challenges. So there's a very significant policy focus in the UK at the moment trying to prevent, through a range of both border measures and targeted screening and isolation measures within the country, of preventing particularly E484K carrying variants growing in frequency at the current time. Thank you.